وعليكم السلام، يعطيك العافية دكتور.
مين الاورجنايزر لهذا الميتينج؟
أنا أعمل في الميتنج دكتور.
دكتور عماد؟
لا، عبد الله القشي.
عبد الله، ممكن تلغي الريكوردينج لو سمحت؟
أكيد دكتور.
لأن هاي المحاضرات كلها عندكم، فما في داعي.
أنا
اوكي.
لغيت الريكورد.
كم متوقعين يكون العدد يا عبد الله؟
كان بالمحاضرة الماضية تقريبا 35 أتوقع.
اليوم كم الحاضرين الآن معنا؟
حاليا 18.
اوكي، ننتظر يعني.
يعني 5 دقائق.
اوكي. exit video.
دكتور، العدد ثبت على 25. إذا حاب تبلش دكتور ما في مشكلة.
كم يا عماد؟
كيف دكتور؟
من كم التوتال المتوقع؟
والله دكتور ما بعرف قد إيه عدد الجروب أنا.
اوكي. طيب. أم، مطلوب منا نحكي موضوعين، اللي هو الاسوفاجيال ديزيز والبيبتيك ألسر ديزيز، صح ولا لا؟ مش هيك؟
دكتور.
طيب. where is this find features. اوكي، سامعيني؟
دكتور، صوت تمام.
اوكي. شايفين السلايد اللي قدامكم؟
سلايد واضح دكتور.
ممتاز. اسوفاجيال ديزيز اللي هي امراض المريء. اوكي. في عندنا two main symptoms للمريء اللي هي صعوبة البلع والألم أثناء البلع. صعوبة البلع بسموه dysphagia, difficulty in swallowing, okay, which refers to the زي ما مكتوب refers to the transit of food or liquid from the mouth to the hypopharynx and throughout the esophagus. We classify it oropharyngeal or esophageal. This should be OE. في خطأ مطبعي هون, I'll correct it. So I'll come to this. I know, we can do this later. Odinophagia is painful swallowing. And it's usually down to ulcerations due to pathogens, like usually Candida and CMV and herpes. Okay? They can come together, by the way, but the dysphagia usually comes alone. But if you have odinophagia, you can have difficulty in swallowing, but you can't have the other way around. ماشي? So you can have odinophagia with dysphagia. طيب. I want to bring this down. As I've just told you, we classify them into oropharyngeal, which is this one, and esophageal. Okay? The oropharyngeal affecting the oropharynx, which can be neurological, the cerebrovascular accidents, Parkinson's, multiple sclerosis, brainstem tumors, any neurological pathogen, okay? And they can be mechanical, like pharyngitis and sometimes neoplasm in the oropharynx, sometimes webs in the oropharynx, or external compression by a thyroid tumor or cervical spine, or sometimes even by lymph nodes, okay? Sometimes radiation will give you oropharyngeal dysphagia, especially if you've had radiation to lymphoma on your neck and your throat, or for pharyngeal cancer, or any type of cancers necessitating upper esophageal and oropharyngeal radiation. Sometimes you may have things like sphincteric disorders in the upper pharynx caused by bars or Zenker's diverticulum. This is all in the upper esophagus, oropharynx. The esophagus body itself is also classified similarly. Motor disorders like achalasia, scleroderma, sometimes motor disorders like spastic esophagus, intrinsic mechanical lesions like strictures, Schatzky rings, carcinomas, eosinophilic esophagitis. We'll talk about some of those specifically when we come to those. And sometimes extrinsic mechanical compression like vascular compression. We've got a very rare syndrome where the subclavian artery runs aberrantly and causes extrinsic compression on the esophagus. This is extremely rare. Sometimes aortic aneurysm does the same. Mediastinal lymph nodes enlargement or cervical osteoarthritis will do the same. Okay, so these are how we classify dysphagia and odinophagia. Odinophagia, as I've just told you, usually due to infections, cytomegalovirus. Candida is probably the most common, Candida esophagitis, but you can have it when you drink caustic ingestion like corrosives, like sometimes trauma, or even if you cause severe inflammation by taking a pill like doxycycline and sometimes non-steroidals, or bisphosphonates, we give it for osteoporosis, okay? Now, achalasia, it's a motor disorder where you get the lower esophagus does not relax, and we classify it according to high-resolution manometry into 3 types. You just need to know there are 3 types on high-resolution manometry. Each one has its own characteristics. Type 1, there is failed swallowing. There's no peristalsis at all on the high-resolution manometry, and this is what you see on barium swallow. Type 2, it exhibits some esophageal pressurization, more than 20% of the swallows, but not completely. 80% is lost. And the same here, you see on endoscopy, but this is what you see on high-resolution manometry. I would not be asking you about high-resolution manometry, but I just wanted you to know that the achalasia, there are 3 types according to high resolution manometry. And there is the spastic contractions, which is type 3. Now, before you label someone as achalasia, you have to do an endoscopy to make sure there is no obstruction in the lower esophagus or in the cardia on retroflex. This is, we're looking backwards in the gastroscopy at the cardia, which is the upper stomach, and we can see there's a tumor here, okay? A tumor obstructing the upper stomach just beneath the esophagus. And it could give you this appearance on barium swallow. So, and even on high resolution manometry, you cannot say a patient has achalasia until you have excluded malignancies in the cardia to exclude pseudoachalasia. This is classical. Who knows what this is? Anybody knows this? Candida esophagitis. Can you see white, yellow plaques on a background of minimal inflammation? When you come to endoscopy, you touch these, they bleed. Candida esophagitis. Everybody with Candida esophagitis, you really have to exclude underlying HIV because it's one of the defining, main defining criteria for AIDS. Okay, so you can't diagnose Candida esophagitis in someone without checking HIV. You have to check HIV, make sure he hasn't got HIV. Treatment of achalasia, we sometimes use botulinum toxin, Botox, that is Botox, sometimes pneumatic balloon dilatation, but the best treatment is actually Heller's myotomy, where you cut those contracted smooth muscles and you release them, most commonly laparoscopically. The surgeons do that. Okay, reflux is probably the most common esophageal disorder. It occurs in normal individuals, and there's usually an overlap of the amount of reflux seen in healthy subjects and those diagnosed with reflux. Okay, the Montreal census says that for reflux, you have to have troublesome symptoms. Okay, the most common mechanisms for reflux is something called transient lower esophageal sphincter relaxation, TLESR, where the lower esophageal sphincter relaxes physiologically and the acid regurgitates backwards. Okay. Now, the message here, H. pylori, especially in when it affects the whole stomach, which is very common in our part of the world, usually leads to low acidity, hypochlorhydria. So if a patient comes to you troubled with reflux only and no alarming symptoms, no family history of peptic ulcer disease, no family history of gastric cancer, and no previous endoscopy showing gastric cancer, you better not to check H. pylori. Because if you check H. pylori and you treat it, the amount of acid will worsen and your hyperacidity will get much worse than before. Okay? This is the Montreal classification of definition of reflux, and this is the magical word. The symptoms have to be troublesome. Okay, you can read that on your own, but that's all what I wanted you to know. Now, symptoms-wise, there are lots of patients with reflux who don't present with esophageal symptoms. Okay, they don't complain of typical heartburn or the symptoms related to esophagus. Many of them will have sinusitis, pulmonary fibrosis, pharyngitis, otitis media. Okay. Laryngitis, asthma, dental erosions, and sometimes even cough. Okay, so don't believe. So not all patients with reflux will present with classical esophageal symptoms. Many of them will present with extra esophageal symptoms. واضح الكلام؟ أنا بحس حالي كأني بحكي مع حالي على فكرة. But I presume you guys are listening, is it? Okay. Risk factors for reflux. Hiatus hernia is very common. Smoking, obesity, because the weight of the abdominal wall will press on the stomach when you're asleep. It will make your acid will reflux further. Non-steroidals, okay. I've already told you H. pylori has an inverse relationship with reflux. So you'll find lots of other factors that are not definite, but it's associated with IBS, family history of reflux, anxiety, and depression. And I've already told you the extraesophageal manifestations associated with reflux. They're already here, like I've just shown it to you on an earlier slide. We classify reflux endoscopically into 4 grades. That's not for you, just I wanted you to know that on endoscopy, this is the lower esophagus. And this is the Z line, the gastroesophageal junction. Can you see it? We're changing from simple columnar, from non-keratinized stratified squamous, like in the skin, okay? But it's not keratinized. This is the lining of the esophagus, into simple columnar lining the stomach. And this is the Z line where they meet, okay? And if you look here, that's ulceration. That's due to reflux at the Z line. This is another ulceration. This is this is worse. And this is structured. This is called grade 4 on Los Angeles classification. So this is what you see endoscopically. Ulcerations in the lower esophagus at the gastroesophageal junction, okay? Therapy, there are lifestyle changes. Cut down your weight, avoid coffee, cut down on tea, avoid sleeping within 2 to 3 hours of dinner time. دائما لما تنام ما تكون معدتك فيها طعام وتكون اتعشيت بكير. هاي كلها شغلات يعني we advise patients stop smoking is very important. Avoid non-steroidals and lose weight. So you're working on the risk factors which I told you about here. So cut down on weight, avoid smoking, avoid non-steroidals, and take your medicines. The best medical treatment are your proton pump inhibitors. Sometimes surgery and what we call Nissen fundoplication is required, especially for patients with large hiatus hernia. Barrett's esophagus, what is it? It is when this part of the lower esophagus, this area becomes replaced by small intestinal columnar epithelium. And that means this, see? And it's ending up here. Sometimes this is a precancerous condition which can lead to esophageal adenocarcinoma like this one. Okay, so what is it? Change of the distal esophageal mucosa from squamous, and I told you it's stratified squamous, non-keratinized, stratified squamous, to intestinal columnar epithelium with goblet cells. This is called intestinal metaplasia. Usually asymptomatic, and it's diagnosed on endoscopy, confirmed on histopathology. It can progress to dysplasia and adenocarcinoma, okay? It's a pre-malignant condition, as I've already told you, not squamous adenocarcinoma. Risk factors for Barrett's and adenocarcinoma are the same. Risk factors for adenocarcinoma reflux, which can lead to Barrett's, most of the time, reflux causing adenocarcinoma through the pathway of Barrett's esophagus. Same risk factors, we told you, obesity can cause reflux, can cause Barrett's, commoner in males, smoking also a risk factor for adenocarcinoma, okay? Some people that believe alcohol is more associated with squamous type of esophageal cancer rather than adenocarcinoma, okay? Management of Barrett's, PPIs, and if there is dysplasia, you use radiofrequency ablation. Sometimes if it's localized, you resect it endoscopically, and sometimes you need surgery. Ongoing PPI therapy may inhibit the development of dysplasia and Barrett's. However, there's no real proof that even if you give long-term PPI, or even if you do surgery for reflux, that is, there's no real proof that can reduce the incidence of adenocarcinoma. And I've already told you this is the Barrett's. You see, the normal Z line, which was here, has now become replaced by mucosa lined by intestinal mucosa. It's called salmon-like. زي لون لحمة سمك السالمون. red salmon-like appearance. And it can be continuous, or it can be in islands, زي هيك. And it can sometimes be continuous to a level and go in islands above. But that's not important, but just remember it is precancerous. Eosinophilic esophagitis, this is another condition which can cause dysphagia. And it's like atrophy of the esophagus. How do we diagnose it? We diagnose it on endoscopy by taking esophageal biopsies and send it to histopathology. And usually you see eosinophils more than or equal 15 per high power field. Okay, this is on histopathology of esophageal biopsies. Treatment, PPI, and sometimes we give typical steroids. There are tens of GI conditions that can mimic eosinophilic esophagitis, ranging from celiac and Crohn's, and sometimes even infections, and autoimmune disorders. But most of the time, it depends on the classical presentation of the patient. They usually come up with dysphagia, food-like bolus impaction, بحسوا لقمة الطعام شابكة في المريء. And when you do endoscopy, you find almost nothing, you see, but you take histopathology and it confirmed there are more than or equal 15 eosinophils per high power field. Now, eosinophilic esophagitis they usually come up with reflux at the same time. It's not separable from reflux. They're not usually separated from reflux. Many of the symptoms of reflux and eosinophilic esophagitis, they come together. But there are other conditions which can give you eosinophilic esophagitis. So that's why if you see reflux on endoscopy, you cannot ask the histopathologist to exclude eosinophilic esophagitis, because even in reflux, you see high eosinophil count. So if you don't see anything on endoscopy, let's say you took the patient with dysphagia and you found this on endoscopy, you can't be taking esophageal biopsies and asking the histopathologist to exclude eosinophilic esophagitis, because there will be high eosinophil count near the reflux area. So that's why you cannot, it depends on endoscopic findings. You see most of the time nothing. And if you see nothing suggestive of reflux, you take esophageal biopsies and the histopathologist comes up with the diagnosis. This is what the patient comes in with. Food impaction like sensation, food bolus impaction. He sensed that the food got stuck. You do endoscopy, you find this, you remove the food, and you may find sometimes you may see trachealization. كانك تطلع التراكية. Can you see those ring-like patterns? شايفينهم? And here, sometimes it may suggest eosinophilic esophagitis. And you take it, you find high number of eosinophils per high power field. The histopathologist will count more than 15 in high power field. And that's how you diagnose it, okay? That's how you diagnose it. Now, how do we treat it? PPI is important. Systemic steroids, we don't usually give systemic steroids. We give topical steroids, fluticasone or budesonide. Sometimes it's related to what we call 6-food. So that's what people think, this what sparks the disease. And mainly wheat, milk, eggs, soya beans, peanuts, and seafood. The difficulty is who can avoid all these foods. It's very difficult to come off all these types of food. So that's why we do advise patients to try to cut down, but most of the time patients cannot come off all of them, but to be careful. So if he's eating excessive eggs, maybe cut down, but these are the type of foods he should try to eliminate to try to feel better. But why all of these? Because they're all rich in proteins. Wheat, milk, eggs, soya, peanuts, tree, and seafood. All of them are rich in proteins. It's an atopy type of reaction, okay? And that's where targeted elimination of diet based on the allergy test findings. This is not very good, but we usually advise patients PPI, topical steroids, and 6-food elimination diet. Okay, that's our esophagus. Clear?
نعم واضح دكتور.
سهلة؟
إن شاء الله.
المحاضرة سهلة صح؟ Okay, I want to attach something else when أنا بسم الله الرحمن الرحيم. Okay. let's see what I wanted to do. This one. عندكم هاي المحاضرات صح كلها؟ اوكي بيبتيكال ستديز. انا مستعجل ولا ام اوكي؟ طمنوني.
لا عادي دكتور.
سريع انا سريع.